thank you very much. And I finish here. I'm sorry for being a few minutes late.
Thank you very much, Christina, for such a wonderful presentation on new staging system in Huntington, extending the window of testing and treatment. We already have many questions in the chat. So I'm going to ask the first question on behalf of Emilia Sitek from Medical University of Gdańsk. Are you planning to incorporate 3.1, 3.2, 3.3 to integrate your new criteria with criterion based on TFC stages?
So I already mentioned that. So the TFC stages is what is called the Schussen and Fun staging system. And so we are currently making those calculations, creating the map. As I said before, the Schussen and Fun staging system only applies after clinical motor diagnosis. And so very likely only maps to stage 3 in HDISS.
Thank you very much. So we have another question from Matthias Dos. What about psychiatric symptoms to be, besides motor and cognitive symptoms, integrated to staging in mutant and gene carriers, which in some cases can be specific for HD?
No. So the point is, the data is very clear. Psychiatric symptoms are part of the phenomenology of Huntington's disease, but they don't progress with the disease, with maybe the only exception of apathy. But even when we model the data, the psychiatric symptomatology does not show sufficient information. So the fact that this system does not include psychiatric symptoms, it's not a weakness, it's a reflection of the data. And of course, people that have psychiatric symptoms will still be staged. They will be staged. And there is almost nobody that does not, that has only psychiatric symptoms and they don't have any other aspect of what we just capture in the system. So people with psychiatric symptoms will be staged using the staging as we have it, even if the staging does not contain a criteria for psychiatric symptoms, if this makes sense.
Thank you.
Thank you, Christina, for a fabulous talk and information. Am I muted? No.
No, you're fine.
So I'm going to start with my own question right now, and that is, will you eventually go back to, let's say, everybody who's on enroll and stage them at some point?
Yes, it's already done. So,
okay.
So there are two aspects to this. For doing this modeling, we use the enroll data and we had to calculate the stage for those. The fact is, as all of you know, enroll is a live database and it's growing. So we have two approaches to this. We are going to calculate the stage to everybody, but we are also making this calculator available. So anybody, any person can calculate the stage as well. But yeah, the answer is yes, we are doing it.
So our next question is from Ed Wild. Everybody knows who he is. He says, thanks, Christina. This will be a valuable tool for research and trials, of course. But do you think it will start to be used in clinical practice? That is, will it be scanning patients and telling them they're at stage 1?
Okay, that's not the intent at all. So we developed this for research, but good research in the long term spills up to clinical practice. That's the nature of research. So research usually evolves, it's adapted, and one day is translated to clinical practice. Does not make sense to do clinical research if it's not the intent to help patients and to translate to clinical practice. So I would say this system, as we have designed it now, it's intended for research. it's very likely that in, let's say, 2 years, 3 years, there will be a new version, an evolution that will be more adapted for clinical research and that for research practice, and that can happen. That's what happened in Alzheimer's disease. They started with a research framework, and after 10 years, there is a spillover to clinical practice. So it's natural evolution.
So there's 2 more questions, and the one is from Anne Rosser, and she says, thank you for beautifully setting this impressive work in context. Will it be possible to keep the calculator updated as new phenotypes with biomarkers emerge?
Okay, the calculator will always be updated if we do updates to the staging system. So the process is, the calculator, yes, will be updated. The staging system needs to be in a fine balance, because if we want a framework that is harmonizing, we cannot be changing it every month or every 6 months or so. So the updates to the framework needs to be very carefully evaluated. But if there is updates, there will be translation to the calculator. The other issue is that new biomarkers, new assessments will always be mapped to the staging system. So there is no need to update the landmarks, because we can always map the new assessments to the staging system. So the answer is yes, we'll update, but we'll be careful. We don't want to change the landmarks too frequently.
And so our last question, because we need to move on to the next session, is from Jean-Marc. And he says, this is great, and I like your talk very much. We have very scarce, reliable data from China and other ethnics. Do you think the model will indeed fit in those regions?
Of course. So that's an extremely important point. And as Jean-Marc well knows, yes, we don't have a lot of data, but the few data that we have, and we review that. We review the cohorts that has been published in Asia, including the Chinese ones. Most, again, sample size are small, but from what we reviewed, they fit the model. And hopefully we'll get a good cohort from China to validate the model against. Yes, I'm very optimistic that it will work in other ethnic backgrounds, but we still want to do that work.
Okay, thank you very much, Christina, for such a wonderful session. And we're looking forward to further results. And I think now we can move to the next session.
Thank you.
Thank you. Bye.
Bye. And thank you very much for telling us about this important piece of work.